la sesión de enfermedad estructural y los que están online, buenos días y bienvenidos. Voy a darles una pequeña introducción. Neal, I'm going to do this in Spanish, and then I will just say a few words in English. So first, Neal ha tenido una carrera en el Hospital Metodista, pues probablemente por más de 35 años, o no sé si cerca de 40. Yo era interno y Neal ya había terminado su fellowship y tuvo una posición de junior faculty hasta ser profesor de medicina en Baylor y eventualmente ahora en Weill Cornell. Ha sido director del laboratorio de cateterismo y hemodinamia por... How many years have you been the director of the cath lab, Neal? 25 at least.
23, yeah.
I was going to say 25. Yo aprendí hemodinamia con Neal por mucho tiempo. Ayer estuvimos platicando un poco las primeras biopsias que yo aprendí a hacer. Él hacía todas las biopsias, después yo hice biopsias. Yo hice un año de intervencionismo. Neal era el director del cath lab junto con Al Reiser por muchos años. Y cuando empezó todo el tema de estructural, hace 15 años, pues tomó un poco más el rol de estructural. Entonces, Neal ha tenido una carrera desde los inicios de trombolisis hasta hacer angioplasia primaria, el desarrollo de stents. Tuvo por muchos años laboratorio básico para entender el rol de plaquetas y el rol de agentes antiplaquetarios. Participó, yo creo que prácticamente todos los TIMI trials desde el origen. Entonces ha tenido una carrera en intervencionismo por muchos años y los últimos años se ha dedicado más a enfermedad estructural. Los programas del Hospital Metodista, ayer nos estaba platicando, yo no tenía una claridad, hacen unos 300 casos al año. Mike Reardon estuvo aquí hace un mes y compartió un poco la experiencia. Entonces ahora vamos a hablar de Neal, una experiencia diferente, un approach muy particular de mucho expertise técnico en el caso de TAVR. Neal, thank you for being here. I really appreciate your time. I know it's not a very big flight, but it still takes 2 days away from work, which may be sometimes pleasant, but it's still hard to get around and hard to come here and make the effort. So thank you for being here. I gave them an introduction of your career, a span of over 35 years. And I will say just briefly that I was an intern in medicine and he probably had already completed fellowship and he was a junior faculty. And I remember at those times, we were just beginning to do thrombolytic therapy, and doing thrombolysis was a big deal. It was only the faculty that would inject the thrombolytic agent and cardiology faculty. And so I vividly remember doing some TIMI trial at the VA, and I was an intern or a resident. You would come by and it was a big deal, right? So there's these coronary occlusion, you see the EKG changes, and then he would come and inject TPA, or I can't remember what drug, and then eventually the EKG looked better. So it was really amazing. So anyway, so I recall, and I have those vivid memories from way back then. But life is different today, and now he's an expert in structural heart disease. So Neal, thank you. You can do everything in English, and maybe we'll ask questions in Spanish and then translate it.
Okay, well, muchas gracias. I'm very honored to be here. Those were very kind words. I'm not sure I can remember what drug we were injecting also, but I would warn you, you're getting to an age, I'm a few years older than you. You can't say, I don't remember anymore, because then everyone's thinking
There's
something.
triggers of dementia.
Yeah. Well, just about. At least people start to wonder. So, look, it's an honor to be here. I had a great time meeting with everyone yesterday. As I told Dr. Paredes, meeting with people is probably more important than doing a lecture, but nonetheless, here I am, and here you are. So I was asked to talk about coronary access after transcatheter aortic valve replacement, or as the rest of the world calls it, transcatheter aortic valve implantation. So if I use the word TAVR, it means TAVI. But, you know, we use the word TAVR because that's what it took to get paid when we started. So,
the other.
Oh. Okay, so these are the considerations. So I want everyone to be able to recognize how frequent or infrequent the problem is. We'll talk about mitigating or easing the difficulty of coronary access after TAVR. This is a topic that people love to talk about without much data, and there just really aren't much data. Everyone imagines that it's going to be very difficult. Everyone imagines that if you use a long frame valve, like a core valve, or until recently an accurate valve, it would be impossible. I'll show you that's not the case. But it really has turned out to be much less of a problem than we imagined when we started. So I'll talk about ways to make it even less of an issue. I'll talk about some of the techniques we have to achieve coronary access. That's it.
Maybe.
Yeah, I remember what this was. And I'll talk for a few minutes about moving forward. If I run over, if I'm running short, just tell me. So, like everyone else, I have biases. And unlike lots of people that I know, I'm upfront about them. I want to admit them. So, first of all, coronary access is part of a lifetime management strategy for patients. You can't talk or think about coronary access without thinking, what's this patient's trajectory going to be? What are this patient's major problems going to be? As I've said, I think the need for coronary access is overstated. And I think the difficulty of coronary access is also overstated. So I can tell you that this guy who puts in a lot of valves, I rarely worry about it. So first of all, recognize that when you're talking about coronary access and you're talking about what's down the road for patients, you have to recognize that when a patient has aortic stenosis, needs an aortic valve replacement, and you replace the valve, it's unlikely that you're going to be putting them back on a normal life trajectory. Now, we don't know that for a fact from TAVR. We don't have data that go long enough. We do have those data from the surgical world. So these are data published by the group in Sweden. And as you know, in Sweden, every patient is registered. Every patient who has any illness in that country, any procedure, is tracked methodically and goes into a registry. So a few years ago, when the Sweetheart Registry people decided to publish their information, one of the things they looked at is loss of life expectancy. How long is someone going to live after they've had a surgical aortic valve replacement? They've got long-term data, but what you can see in the graph on your left is that you lose life expectancy. And if someone has an aortic valve replacement in their 50s, they lose about 5 years of expected life. Now, it may be better for TAVR, it may not, we'll see. And if you look at expected survival, if you're a man and you're in your 60s and you have a TAVR, your median survival is about 16, 17 years. If you're in your 70s, where we're doing many of our TAVRs, you're getting close to 11 or 12 years. And if you're in your 80s, where every aortic valve that's replaced now is TAVR, your mean survival is less than 10 years. So when you think about future coronary access, keep that in mind. Now, the other part of this equation is we go into TAVR knowing what a patient's coronary status is. And everybody gets a CT scan. before TAVR. That's how we choose a valve prosthesis. That's how we choose which device we're going to use and how big it's going to use. But the other thing is we can look, and we do look at the coronary arteries. We don't catheterize everyone who has a TAVR. If someone is said to have normal or minimally diseased coronary arteries on CT scan, they don't need a catheterization. That's an extra procedure. Now, the CT people always tell you that the study's not optimized for coronary artery disease, but if they see no calcium and no lesions, you know you're in pretty good shape. And in fact, there are lots of data available now that tell you that based on CT angiography, you can make a very good guess as to what a patient's long-term likelihood of having a coronary event is. If someone has normal coronary arteries, you follow them out, their coronary risk is very low. This isn't rocket science, but like many guesses, it takes data to support it. Now, the other thing I want everyone to recognize is that we must be doing something right with these patients in addition to the aortic valve. We've looked at the frequency of acute coronary syndrome in patients who've had TAVR. And if you look at a variety of studies, it's really fairly low. So we're talking about 11% at 10 years in the NOTION study. Its patients had an average age of 78. If you look at the PARTNER and core valve low risk studies, these numbers are less than 5%. Average age 73 years. SIRTAVI, average age about 77, 78. 6%. PARTNER 2 is higher. REPRISE is higher. But these numbers really are surprisingly low. And maybe it's because we screen patients, and if they have severe coronary artery disease, send them for surgery, for an open repair and bypass. Maybe it's because once they get plugged into the system, we say, whoa, your LDL cholesterol is sky high. You need to be on a high-dose statins. Maybe it's a combination of all those things. And I like this piece of data. The reason I like it is because it was published by my former fellow. This is the Vizient database. So these are largely insured patients at hospitals in the United States. More than 200,000 patients who underwent TAVR. Median follow-up, almost 3 years. Take a look. The incidence rate of STEMI was 25 events per 100,000 patients. The incidence rate of non-STEMI was higher, but it was still 229 events per 100,000 patients, per patient year. So frequency is low. Keep that in mind. So how often does angiography turn out to be needed? These are a variety of studies. I have not updated this recently, but take a look. The numbers are low. Well, I've got to figure this out. And how frequently were people successful? These are the published figures. And again, success rates are high. As I'll show you, some of that comes from success, comes from experience, some comes from persistence. These are our own data that we presented last year. So in a 13-year period of that time, 2% of patients we've done required PCI. At a mean of about a little more than 2 years. Femoral access used in 96% of patients. Now that number is considerably lower. Total of 44 PCIs, so not a lot. Didn't see any difference between balloon expandable, stapling valves, and self-expanding core valves. Now this number is an underestimate. It's probably higher because they're probably our patients who had PCI elsewhere, we didn't pick up. Although truthfully, at 1 or 2 years, we've seen all those patients. They have to come. In the US, they have to come back at 1 year for a follow-up. Otherwise, we don't get paid. Those are the Medicare regulations. And if we see them at 1 year, we'll usually make an appointment for 2 years. So the follow-up may be incomplete, but short term, I don't think it's very high. So a few years ago, I wrote this editorial, sort of the only editorial I've written that anyone's ever read. I called it Monster Under the Bed because children are always worried there's a monster under the bed. We as mature individuals know that that's not so. This is something that I believe people are more afraid of than the data would indicate that they should be. Okay, so what solid data are there other than case reports like ours? So this is the most recent one. This is the caveat registry reported by Dr. Tarantini. And what they did is they intentionally performed coronary angiography immediately after TAVR in every case. At least the intent was every case. And take a look. Short frame valves. So now, I think as an editorial, it's time to abandon the terms balloon expandable and self-expanding valves. There are lots of differences among valves. So, taking 3 valves, 89% success rate. So, it's pretty clear if you look at enough patients. Short frame valves don't sit in front of the coronary valve. The skirt that is used to seal paravalvular leaks doesn't come up very high. The valve itself is annular rather than supraannular. So it stands to reason that it's easier to do a catheterization. And in fact, the data support that. And you have to remember the other factor that people don't talk about is that even a short frame valve comes up, sits in the sinuses of Valsalva. It may not cover the entire sinus of valve. The frame may not cover the entire sinus of Valsalva, but it decreases the room that you have to manipulate a catheter to get into a coronary. And take a look with the Evolut Pro valve. Granted, this isn't a valve we use anymore. The success rate is lower. So green catheter cannulation of both coronaries. Yellow represents successful angiography, whether the catheter is engaged completely or not. Red is complete failure. And it turns out that for self-expanding, for Evolut Pro valves as opposed to other valves, it was easier with big valves than small valves. Stands to reason, again, if you have more room to manipulate a catheter, you can do more things. Okay, I have a few caveats about that. An important one, single diagnostic catheter for each of the 2 coronary arteries. These are mostly Judkins catheters. 94%. With the Evolut Pro valve, multiple catheters were needed, so 13% for the left, 17% for the right required multiple catheters. A couple of things. So think of how this registry is done. Really important. Immediate angiography in a patient who have completed TAVR. What do I want to do when I complete a TAVR? Well, what do I do? I say, thank you, God, and I want to go sit down and have some coffee or something to drink. I don't want to spend a lot of time doing something additional that carries a little bit of risk. So if you look back at these success rates, they don't report the time required for your job, which I think is an issue, because if I've completed a TAVR, patient's doing well, my heart rate goes from 120 back down to 60. I'm happy. I don't want to spend a lot of time trying to manipulate catheters. So my failure rate's going to be high. or higher. So they didn't, these were not young patients, average age was 82. SDS predicted risk of mortality was 3.2. They didn't report the time it took to engage the coronaries. And they used older valve versions. So now when we use core valve, we use the Evolut FX Plus. Do you have that here? Okay. You'll auto relieve on electronic pretty often. And what's unique about this valve is it's got an area where the diamonds are separated. So there are two ostia separated by 120 degrees. And the idea is that if you align the valve properly and the coronaries are where they should be, it's very easy to cannulate the coronaries with this valve. And so this is a case that one of my younger partners published at the end of last year, just to illustrate, and we did a CT scan post-operatively on this patient. Here's a picture of the valve. We can see the arrows indicate the coronary ostia. Lined up quickly. We actually catheterized this patient. Just as I said, I would never do. We did it. It took less than 1 minute to cannulate the right, less than 1 minute to cannulate the left, 1 minute and 28 seconds to cannulate the right.
It's the CT before. You had the CT before they had
this. CT was done afterwards. So we put the valve in. We said, let's see if we can get catheters in. And it worked out quite nicely.
Would you suggest to do a CT before cannulating?
If you
It's not necessary, but would you suggest?
If you can, I think that's very useful. I think that's very, very useful. Particularly if you don't have this. The other thing I'll show you I'll show you now. Can we back up? That's out of order. Next. Talked about that already. Next. Okay, let's get a little out of order. So look, as I said, we do screen patients. We, once they're in the system, we're aware of their cardiac status. We treat their risk factors for coronary artery disease. The other thing we do is often we take care of the coronary lesions before we do the TAVR. And this is still debated. I've debated both sides of the issue in the past year. I would like to say I've won both debates, but I'm not sure. This is the Motion 3 study that looked at prophylactic PCI before TAVR versus conservative management of significant lesions, showing out to 5 years benefit from PCI in terms of preventing myocardial infarction. Not big enough to look at mortality, but everything seemed to be in the right direction. Huh. Well, I wanted to show you a slide. You asked about CT, and that's really important. Let me stop here. The having a device with 2 coronary cannulation ports at 120 degrees is great, but it makes an assumption. And the assumption is that the coronary arteries are where they're supposed to be. Now, any surgeon can tell you that in patients with bicuspid valves, the coronaries are rarely separated by 120 degrees. It's usually more. There's a great study from Spain published 2.5 years ago that looked systematically at coronary locations. And they found that about 20% of coronaries in patients with tricuspid valves were not aligned. And if they weren't aligned, then the likelihood of successful cannulation was a lot lower. And there were cut points. The cut point was 19 degrees out of position for the left coronary. So anything more than 19 degrees was considered severely malpositioned, and 24.5 degrees for the right coronary. It was more commonly seen in the right coronary being out of position, as you might guess, than the left. So that, I think that study did not receive the attention that it really deserved. I have a slide of it. It'll show up when we least expect it. Okay, so how do you predict successful cannulation? Well, there are a few things. Valve design, tall versus short frame. Short frames, as I mentioned, make it easier. The accurate valve, which was recently taken off the market, was an exception. That was a tall frame supraannular valve that left lots of space for you to be able to cannulate. Didn't turn out to work so well. The other thing that always concerned me about the valve is the design always looked like you were going to catch the valve with a catheter and pull it out. When we implanted those valves, there was a lot of pressure on us to avoid pulling the pigtail out without a wire, in the fear that the pigtail would hook on and pull the valve out. I don't know how often that's actually happened. Probably not very often, but it's a concern. Anyway, that's not an issue.
But you, talking about 2 years after the implantation?
Well, we never got out to 2 years. So acutely, yes. 2 years later, I would still be worried if you're trying to do a PCI and you're using a guiding catheter. That's pretty rigid. And you can pull a valve out doing it. That's been reported. So things you do have to take into consideration: valve design, short versus tall frame, supraannular versus intraannular. So short frame intraannular sapien valve, as I showed you, is easier to cannulate the cardiacs.
Just keeping on up with this. Now, we usually focus on the aortic growth, but what is a paper that the ascending aorta takes in the picture has not been studied? I mean, because we have a bicuspid, it's going to be dilated. Even if you don't have a bicuspid, if it's a long-standing aortic stenosis, you will have a dilatation. So if you're using a radial, will that help you? I mean, knowing beforehand, will that help you deciding which catheter to use to kind of?
The answer is yes. We do have one slide that will show that. Doesn't talk about, I don't have anything about angulation. I'm certain that has a lot to do with it. That's not been studied to the best of my knowledge. But I have one that shows you with a big aortic root. It makes life a lot easier. At least that part of life. So back up. Again, commissural and coronary alignment are something that you have to keep in mind. We talk, and surgeons talk a lot about commissural alignment. And that's important, probably with regard to valve function, possibly durability, possibly paravalvular leak. But again, if the coronaries aren't where you want them to be, commissural alignment doesn't help. It's coronary alignment, and you really want to make sure that the center of each cusp sits in front of the coronary artery, not post, not the commissure. That's where the posts on the valve are. And then I said operate, and I made the slide up. I said operator skill. It's not operator skill. It's operator patience, because sometimes it's going to take you a long time to cannulate the coronary artery. And so part of that is knowing how badly do you need to do it. And part of it is knowing if you work at it, you will get it. Our success rate's 96%.
Neal, I'm sorry to.
No, don't worry, this is supposed to be, I like interaction.
Okay, so pre-cath CT does not help you to define the angles of the imaging, maybe the type of catheter?
What it does is it helps you define how you want to try to align the valve.
Okay.
So if I know that the left coronary is out of position, and I've got the valve movements are always separated by 120 degrees. That's the way the valves are designed. I'm going to try very hard to make sure that the middle of the left leaflet is sitting in front of the left coronary oscillator. So I'm going to go use the CT to choose a view that shows the left coronary oscillator on top. Usually it's an LAO angle. And I'm going to try to orient the valve so that my leaflet ends up there. Sometimes that's successful, sometimes it's not. I'm trying to have a conversation with God about placing the coronary arteries, but it hasn't been very successful. Okay, so one thing you do have to recognize is to know the valve specifications. And I can never remember the numbers. I always have to look these up. With core valve, it's pretty easy because the skirt height is between 12 and 13 millimeters. 12 for the smaller valves, 13 for the larger valves. I can never remember at which point it shifts. I always have to look it up and ask. For those of you who are my age, that's why we used to have phone books. If you really remember someone's number, you can always find it. The other thing that people who aren't experienced often forget is the valve, or the frame diameter is important as well, because we're used to using catheters based on how big the aortic root is, but if you're working inside the frame, this is going to be narrower than the ascending aorta and the root. So we're going to start off with a smaller catheter. At least that's been the classical teaching. Now, that doesn't always work out. The other thing is if you look, particularly at the core valve, you count the nodes. And it's up at the fifth node that the skirt is, and that you ought to be able to get a catheter into the coronary. Now, again, this is going to depend on the valve implantation depth. The deeper you implant a valve, the easier it's going to be to get into the coronary. Although when you do that, you make some sacrifices in terms of pacemaker risk, paravalvular leak, and possibly valve durability. So those are things that are really important for you to keep in mind as you're implanting.
Do you make those considerations in your pre-planning procedure? Like if you know that you're likely to intervene in the future, will you choose a lower position of the valve versus
you'll either choose lower position of the valve or you'll choose a short frame.
a different valve? Yes.
Yeah.
So, okay.
Now, I say that 70% of our implants are core valves. It's just the way our culture at our hospital has grown up. But we will make some of those changes when we're thinking about coronary access. And then there are a variety of ways, different for each valve, that have been developed to try to get coronary alignment. So at the time of implantation, there are a number of things that you do. Okay, so this is the core valve evolute. So you start off, even before you implant the valve, even before it goes into the body, you line the valve up to the best of your knowledge, the best of your ability. Now, we're taught to place the flush port of the valve at 3 o'clock. In our experience, it's about 2 o'clock. That seems to work better. And then there is a thing called the hat, which represents the edge of the valve. Looks a little bit like a hat. I don't know how well you can see this. I had to struggle with it to get the hat to line up. So if you take a look at this, this should look like a baseball cap. Okay. If you're in the LAO view, as you are coming up the descending aorta, this should be in a greater curvature. Now, sometimes we've twisted the valve on the iliac, so we always move it back and forth a little bit, just below the aortic arch, to make sure that's lined up. And then as you come around, as you go to the cusp overlap view, which we use to start assessing our implantation depth, it should still look like this. Actually, you're there. It should look front and center. I think the next slide should show that. Yeah. So this is the case. Here's the hat marker on your left. You can see the part that looks like a portion of the baseball cap that goes over the head. There's a greater curvature. And then as we come around to the cusp overlap view, the hat marker is front and center. The other thing that you should see, which you don't see very well, is these valves now have dots on them to indicate the cusp position. And with the core valve, you want to make sure that you have 2 dots on the left side of the screen in this view. That tells you that your alignment is likely to be adequate. This is a navitor valve. It's a little bit different. This is the navitor vision valve. And what you can see coming up with the descent aorta, there are marker dots here. And with this valve, you start at the flush port, not at 2 o'clock, but at 12 o'clock. And then you align these dots, so 2 dots are on your right. So these are things that, as you put these valves in, you try to remember. And the truth is, you've got to get it right going up around. You can't really rotate these valves once you come around the arch. And you don't want to come back and realign it, because every time you cross the arch, you risk embolization and stroke.
Is the breaker also a shorter skirt?
It's a shorter skirt or a shorter frame. So it's annular rather than super. This is what I wanted to show you earlier. This is the Spanish study that I think is great. And really doesn't get nearly the amount of attention. But it just shows you that it's very common. Upper right is a histogram of the distribution of right and left coronary locations. And as you can see, it's more common for the right to be out of its usual expected position. But it's something that's important to know. And the bottom right just shows you that the farther out of position coronary is, the less likely you are to have proper coronary alignment. So we've moved from commissural to coronary alignment, which in terms of access is going to be important. That's one. Okay, so I want to show you a number of cases. How will the time was?
We have time.
Okay.
It's 10-15 minutes.
Okay, that's perfect. So, as I said, you've got to think about the patient, what the patient's objective is when you plan the TAVR. So, for example, we had one young operator who had his the first few months. And he presented a patient. The patient was 85, had 50% lesion in the mid-right coronary artery. Small woman, small annulus. So small woman, small annulus generally will use a core valve because you get less likely of a prosthesis patient mismatch. But this guy said, well, I'm worried about the right coronary artery. That wasn't the right approach. The right approach is 85, single vessel, mild coronary artery disease. What's this patient's problem? The problem's not the coronary artery disease. It's the aortic stenosis. So this guy's the opposite. So this guy, late 50s, early 60s, a few years ago, comes to see me, says, I want a TAVR. I said, okay, let's figure out what you have. So we had critical aortic stenosis, catheterized. He's got pretty severe coronary artery disease. He's included, he's got a circ lesion, his right's pretty ratty, but it's got a focal lesion. So look, you know, you're early 50, or late 50s, early 60s, you need to have a surgical aortic valve replacement to bypass it. I said, you're going to live a lot longer. Your likelihood of recovering from surgery is about 99.5%. But this guy's insistent, back and forth for several clinic visits, still couldn't convince him. So dilated the circ, and went ahead and put in a sapient valve, and everything went smoothly. Comes back, I have a CTO guru, open the LAD, that went smoothly. The guy has done fine. He chose the treatment that obviously, I'm a man with a hammer, everything looks like a nail, but he would have been better off with surgery. I still think he would. But, this is why we talk to patients.
Maybe we should talk about it later. See, the patient wants this and it's not the best treatment. Should you do what they want versus what's
right?
So that's an important thing.
As you know, there's a certain population that I deal with where every case is a low negotiation. Okay, so this is one of the first cases I did. When we started doing it. So this guy had a straightforward TAVR, which wasn't so common back in 2012. Did well, comes back with acute coronary syndrome, lesion in the distal right. So what we actually did with this guy, this is what you want to be able to do, is we were able to slip the catheter behind the frame. So we didn't cannulate at the level, we didn't cross the valve, cross the frame at the level of the coronary artery, which is here. Rather, we came behind it. I don't remember if we were completely behind it or crossed way up high, but we managed to manipulate the catheter between the native aorta and the outside of it.
And that doesn't damage the structure of the valve?
No. These valves are made of nitrile, so you can deform them and
they'll reconform after?
They reconform. But this was great. So that being behind the frame held this catheter in position. It's like having a small fellow who's a scuba diver to hold your guide catheter in position.
How were you able to do that? Just with a wire? Because the wire first behind it.
Yes, and I didn't do that intentionally.
It just so happened it went behind and you were able to follow it.
Yeah, and I said, wow, this is going to work great. And the advantage is it's then buttressed very firmly into position. So guide support
was better.
It's better.
And were you not afraid about dislodging the valve?
Well, this was a year or two later. So the valve is partly endothelialized. If you've ever tried to pull one of these valves out after several months, it's difficult. And the surgeons will tell you that, explanting it from the aorta takes a certain surgical skill or experience. Okay, this is a patient with a large aortic root that you'd asked about earlier. So I don't remember the specifics of this guy, but this is a valve, in surgical valve. You can see the markers on the surgical valve here. Large aortic root made it very easy to get a diagnostic left catheter into position. The other point I wanted to make is that as you plan this, it's very important to set up your views properly. So in this cranial view of the right coronary artery, and unfortunately the slides didn't come out so well, but what you can see is there's a good deal of parallax. If you look closely, I know I said pointing is a sign of weakness, but I'm pointing to, you see one edge of the valve here, and the opposite edge of the valve here. And really what you want to do to assess this is to line them up so that you are perfectly perpendicular to the valve. So you can count how high you're going as you try to cross the frame. So here, I have no idea how high this catheter is, because we're looking almost end-on down the barrel, almost of the valve. In this standard LAO view, the parallax is removed, just about. So you can see the catheter is up at the fifth node where the skirt ends.
Is it possible to sometimes cross the skirt?
No, because the skirt is solid, so you'd have to.
You cannot puncture it, or
You can. You really don't want to. So we've never done that. And I truthfully, you know, it's been done in emergency situations. Coronary is included. Yeah, but you know, truthfully, if you include a coronary, you snare the valve and pull it back. Well, you try to cannulate. If you can't cannulate quickly, which we've been able to do when we had to, you snare the valve and pull it back. So, can we back up now? Back up.
so in a core valve, you could always try to do an external valve cannulation. Is it possible? Would that be a preferred strategy?
To come behind
To
you.
go behind that.
Yeah, if you can do that,
That would
that's going to make your life easier, particularly for the right coronary. So coming back to this guy was cath last week. We had put a valve in him about 4 or 5 years ago. He presented with that. So the referring doc catheterized him with a radial access. Had no problem. Said, okay, look, you know, this may be a little complicated today. I'm going to come back from the femoral approach. Next slide, please. And he did, and this is as good as he got. So this is, that's Tuesday, a week ago. So they called me up. They said, can you see if you can do this? I said, sure. So Thursday, he comes to our hospital. Now, Dr. Torre knows where I am Thursday. I'm like buried in clinic completely. There is no way I can get out before 6 at night. I wasn't going to do this guy at 7 at night. So we admitted him. And then, so here we are yesterday. Now this is where I say planning is important. This is yesterday morning. Now, where was I yesterday morning? Getting ready to go to the airport. So I said, look, maybe this will be fast, easy, maybe it won't be. I'm not going to start this and then run to the airport. So this is planning. So Friday, I asked one of my associates to do this. So that's to me, that's a really important point. I would have loved to have done this, but I don't want to do this, get a call while I'm waiting to get on the plane and the patient's having a problem. So I asked my associate, Dr. Allen, to do this. So he went back to the wrist. This is actually a left coronary bypass guided catheter. Was able to cannulate pretty easily. You can see there's a microcatheter and a wire in place. And then, once the wire is down the vessel, he used the guide catheter extension. Next, please. And was able to introduce a shockwave balloon. Now you can see he's advanced the guide catheter extension. You can see that the guide is not really in the ostium of the coronary. Was able to get an iris down. So this is an eagle-eye catheter, so it's kind of bulky. Next one. And then was able to get a long stent way down into the posterior lateral patch. Really without much problem. He did this case in an hour. Called me up. I'm sitting at my desk. He called me up and said, well, I did the case. And I said, yes, I know. I've made slides already.
So you just picked him up from Epic?
Yeah, from Singapore.
So, but the guiding was always outside the coronary ostium.
Once the guided catheter extension, the telescope.
Then he just got out from the coronary.
Well, it kicked the guide back.
And you didn't need to put it in.
Correct. Let's go to the next one. Next. Okay, this is another case where we never really got the guide into the ostium. We were able to advance a wire from the guide into the coronary and then gradually advance the guide liner over the wire. And as you can see, we're able to get a pretty long stent into the circumflex. Next one.
Do you always, you specifically count the struts to make sure that you're above the, because you know you're going to be, yeah. So
you do. Doesn't always work out. But that's where we start. We start at node 5 with a smaller catheter than you would normally use. So if
and these are conventional core valves, are not the ones that are preformed with a wider.
Right.
I mean, these are all valves.
These are all
valves.
This is a guy who had a pop out of his first valve, so we pulled it back, put a second valve in, and then he presented with an acute coronary syndrome. And what you can see is as we had a difficult time cannulating. Looking at your left, that's the closest we got, is an upward takeoff to the left main. We were able to get a wire into the vessel, and then a guide catheter extension. What you can see, this first arrow, is that the guide is way back. It's closer to the right coronary artery than it is to the left. So we were able to complete that case successfully. But let's go to the next one. Yeah, keep going.
So the microcatheter is the way to, that's
microcatheter followed by guide catheter extension. And then this is just another one where we're way back. Actually, the wire exits the frame and re-enters. Okay, it's kicked the guide back so far. But again, if you can get a wire in, you can do the case. You can almost always get a wire. I can't think of any, of course, memory is selective. We haven't had any cases that I can remember in the last 14 years where we've not been able to get a wire into place.
And so the way to have enough support with the guiding way out of the corner is using the microcatheter.
A microcatheter and then an extension.
And then an extension. And then the guiding catheter is really fixed within the structure of the valve, I guess, right? So where outside or wherever you...
Well, in this case, it's not fixed because it's down the center of the valve. So it's in the lumen.
And if you're doing this in a case, Neil, that said within a few months of the implant, would you be concerned about manipulating the guiding catheter and dislodging the valve?
Yes.
Does that
I'd be
mean that
very concerned. I'd be extremely concerned. It's happened. So I would not remove the guiding catheter without a wire and a guide extension in the coronary.
okay, so you leave the extension in the coronary and remove the guiding catheter?
Yeah, push the extension forward as removing the guiding catheter. We've never come close to dislodging a valve, but you know, it's obviously really bad news if you leave the valve dislodged half in the native valve, half out, because then you have torrential aortic recurrence.
Yeah.
Torrential acute aortic recurrence. Yeah, this just shows you how far back the guide is, and you're still able to get equipment in.
And at the end of the day, just to identify the osteum, it'd be just the skilled patients are just.
It's patience more than skill. It really is. I mean, everyone has a formula. There's shots that
The reality is that you just have to work around.
you do. I mean, there are ways to start. You start with a smaller guide. You start at mode 5. If you can get behind the frame, do it. Okay.
I assume that in a safety valve, you can never get behind the frame.
Well, you can. You usually don't have to.
Because of this
It's
curve.
close. And then, you know, again, 4 hours, long case, not easy. But, you know, this guy needed it. Okay, so let's talk about the future. So these are data from the US TBT registry. And what you can see is that there's a gradual decrease in the age of patients undergoing TAVR. I don't know how much you've witnessed that here, but the age at which people come in asking for TAVR is going down. Often we get our arm twisted into doing this in young patients. Personally, I'm very hesitant about doing it. Next one, please. Again, this is another publication by our former fellow, Tanush Gupta. But what you can see is that patients less than age 65 in New England, half of them are getting TAVR.
Half of them are now getting that.
Yeah. There's also data from California that look the same.
So, but that's not the European experience, right? So,
Right. But we have a different landscape.
no, I know. Here will be California and the maximum expression. Everybody's going to get TAVR.
Right. And everyone wants to do TAVR. I mean, I like it.
Right. So no, I mean that's it. But the question is is that the right?
That's the big question. So next slide. So, and you know, the reason I say that is
Versus a biological valve. So we're talking about a biological surgical versus TAVR. Not in a very young person. So
well, if somebody's 60, I want to get a mechanical valve.
you want to get a mechanical valve?
If they're 60, yeah.
I don't know.
No, I don't know either, but make it 59.
No, I mean those are the very difficult questions, right? So in terms of long-term management, anticoagulation, and active lifestyle, I like to think that a 60-year-old today is more like a 40-year-old 20 years ago.
I like to think that too, but as a guy who's pushing 70, it's not quite true. So this is my perspective. These are data from Part 3 in the risk trial, presented at TCT last year. You know, they look pretty good to 5 years, but you know, these are patients who've got a 15-year horizon.
Yeah.
Possibly longer. So we have good data for the first 5 years, but we don't know. Let's go next. And it's been estimated that, you know, as these valves wear out, and we don't know when they're going to wear out. We don't have 6, 7, or 8 year data yet. By 2035, in the US, there'll be 60,000 TAV and TAV per year. That's Philippe Genero's estimate.
And is that going to complicate cannulating the coronary arteries?
Well, I'll show you. Let me show you. There are all sorts of models. Everybody's got a computer model of this. If you believe the computer model, I would suggest you go home and start drinking heavily. Because the computer model predicts that you're just going to have misery upon misery upon misery. This is for coronary obstruction. So far, this is not proven to be the case. The reported frequency of coronary obstruction for TAV and TAV is 0.6%. Yes. So we'll see what it is for TAV and TAV access. But when you do a TAV and TAV, generally you send the data into either Medtronic or Abbott or Edwards, and they give you back a very detailed prediction of what size valve you should use, where you should implant it. They do that for you guys too?
Yeah.
Okay. Now that's important. And remember, if you're putting a valve in a core valve, your choice is to be a seeker. Because you don't want too long frame valve with high skirts obstructing things. I mean, we've done it, we've gotten away with it, but it always makes you uncomfortable. So let me just show you this. So they tell you what size second valve would be, where you should implant it. You implant according to the top of the valve because the sapien valve shortens from the bottom up when you implant it. So you do all sorts of things to make sure you remove the coronary. Back up. One more. No, forward. 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 Keep going. Keep going. Keep going. Okay, so this is what I want to show you. So this is a TAV and TAV. Worked up, spent a lot of time discussing and planning this. So here we are, valves lined up. Next.
And you have the coronary. Where do you have the guidance sensor just to protect the coronary?
Correct. Because if we include it, then we have a stent, an undeployed stent in each one. We're going to pull the stent back to create a snorkel. So here we are, valve and valve, valves expanded, guideliner and stent, undeployed in each vessel. Keep going.
So you have two guiding catheters.
Two guiding catheters and stents in each one. Now, valve goes in, the hemodynamics look great. We then start to take the catheters out. And what happens?
The valve comes up and
The valve probably ended up a little too high. So now each stent, shaft, and guideliner extension shaft are caught between two pieces of metal. Can't get them back. The left corner, the stent slips off. Put in a second balloon, get it through, expand the stent, take the balloon out, balloon breaks. Take with the left corner. Flag balloon is present, put a second stent in to compress it.
So the balloon broke inside the coronary at the moment that you were inflating the balloon.
Correct. Because it's caught between the two valves. Take a look at the right side. See that red arrow?
Uh-huh.
We got the stent out. We could not get guide extension out. Guide extension broke in the ostium of the right. So this was a disaster.
Did you fix it or did you have to go to surgery?
Even this patient's not a surgical candidate. Patient had big infarction. These are things that you need to be aware of.
So we were able to remove the. So what in the right coronary area? What exactly happened?
Well, we're pulling the guide extension back.
You got the extension back and a piece got
I
inside,
got most of the extension back.
and the portion remained in the included the right coronary.
Yes.
So big right coronary. In fact, I was afraid to ask, did he survive or?
So, what would we do differently? The valve moved up during its deployment, which is a little surprising. I was hoping that the wires and balloons would exert a little downward pressure on it, make it harder for it to move up. What would we do differently? Well, we'd start lower. Probably, this time we'd pre-dilate the old valve so that it wasn't pushing the new valve up. So I think we stop here.
Yeah. No, I mean this is a pretty complicated.
It is, it's a data-free zone. I'm not sure what data you use other than to say it can be done. It sometimes is quick.
So Neal, maybe let me just ask a little more general question, because I think the technical aspect is quite sophisticated, but I want to ask more of a general question in this category. I mean, because people are going to face, the general cardiologists are going to be facing complications of patients that undergo TAVR, just like people have seen valve surgery complications forever. So you face a patient that has a coronary syndrome, that has a TAVR. What's happening in the U.S. in terms of the ability of community hospitals to try to resolve it? Are they really referring? Do people understand that these are complex interventions that need to be referred to bigger implant centers, or are the cowboy community hospital interventions attempting to solve the issue? I mean, how is the situation?
I don't know the answer to that. That's a great question. I haven't seen a cowboy film.
So they prefer not to deal with it and send them over.
So
pretty
far,
much.
That's my impression. Everybody knows what a cowboy effect is.
That happens here all the time. There's plenty of cowboys here.
Well, I know, but if you told me in Spanish, I wouldn't understand.
But in Spanish, I don't know how we say that. How do we say that, right? But I think that's an important question, because I think when you go to Methodist or big high volume centers, I think you will have the sophistication of a team of people, the discussion, the planning. You deal with a guy in a small community hospital in private practice, which is similar to what happens in Mexico, right? That will be more the standard. I mean, or eventually.
The standard south of Canada. Yeah, I mean, this is going to be an issue now. Fortunately, it's not very common. Fortunately, if we're talking about lifetime management, you've got to have plans for the management of their other cardiac stuff. And, one of the things we face is we don't want to become those patients' primary cardiologists, because it doesn't do a lot for referrals. But, you want to make sure that their lipids and hypertension really are managed.
Right. So maybe let's go back to the question as to the younger patient that is going to want to get a TAVR because of I'm going to say the false illusion that having a non-chest open, it's always safer, and the perception of less trauma, which I suppose is intuitively correct, at least at some point, at short term. How do you deal with a guy that says, I want this, when you say 55 years old, athletic, has an aortic bicuspid valve with predominant stenosis, you can fix it, and he said, I don't want surgery. What's happening today at Methods, sir? People, like when you discuss in a multidisciplinary team, people let them do what they want, or say no, go somewhere else.
But we haven't sent people somewhere else. I'm sure they haven't. I'm sure they shop. Now, if somebody is young, athletic, they're less than 65. I just asked, look, if you have grandchildren, see we're all. You know, some people are resistant, but there really aren't that many. I mean, if someone says that, have a meet with the surgeon. I always send them to think about it. Bicuspid valves may be a little different because they're usually bigger annuli. There's more room to get into the coronaries. Of course, you may not get as good a result from the TAVR, which is a problem.
So less long-term durability?
Right. The TAVR may be easier, but the problem is if they're left with a leak, or if they need a pacemaker.
Vicente, Pepe, or?
Yeah, I want to ask a great session. I just wanted to ask regarding, so if we look at the guidelines and we look at this recent ESC guideline regarding valvular disease, we're coming to a lower age of patients that getting TAVR. So I think this last slide is going to be an issue in the future for most of them. I mean, the people, and the person that is getting like 2 TAVRs.
Yeah.
So
No, it's going to be an issue.
it's going to be an issue. So how should we anticipate, or how do you guys do it in Methodist? Like, because I've heard a session from Dr. John Webb, and he talks about this term reproducibility. So you have to think of what is the possibility to reproduce the result you have in the first TAVR with the second TAVR. And this is one of the aspects, the coronary access, because I mean, we tend to be more conservative with the patients as we used to be, you know, when the first TAVRs were done. Like most of the patients had like stent, the coronary disease treatment, revascularization, and then the TAVR. But with time, we've seen that people don't really die from coronary disease; they die from aortic stenosis. So we tend to be more conservative. But now, to keep being this conservative with patients that maybe require a second TAVR, and a coronary access may be an issue. Like, how do you guys anticipate these patients? You know,
I think first thing you've got to do is ask, what's the status of the coronary arteries? So if a patient is 65, make them 60. And their coronaries are normal and the risk factors are controlled, it's very unlikely that patients can have an atherosclerotic event. If they have focal disease, I think we ought to be aggressive about stenting.
Before implant.
Right.
Just like a paper you show, and then you fix it, and then
Yeah, and I will send an FFR guide. You know, we'll see when the big defined study comes out, and maybe that, you know, you really need to use FFR guidance to make sure you've got the whole thing. So that's number one. Identify, do they have a problem? If they do, take care of it. I think number two is you work on, be pretty meticulous about trying to get coronary alignment. Again, I think it's harder, but it's less finishing bicuspid valves, just because there's more space. But number three is, it's Greg Fontana, surgeon. It's fun to tell you Pat Stevens and Rod Stewart, first companies fetus. You never want to, you said only I was old enough to recognize it.
I know. Nobody knew it.
Great song.
No.
I
guess they didn't hear you.
You want to get a good result from the TAVR. You don't want to say, oh, yes, I implanted it, so I have great coronary access, but even though I have moderate regurgitation, or even mild regurgitation. And then I'm hopeful that in the future, devices like a shortcut device, which is basically a long pair of scissors that let you cut the existing leaflets, will come into common use. Right now, that pair of scissors is $25,000 in the US, so we don't have it yet. Then the other thing is, I want to see where the 8, 9, 10-year results in those patients are. I'm concerned about that. I don't think that's an answer.
So what is the overall feeling of durability of a bioprosthetic surgically implanted versus TAVR? Yeah, I guess that's a really important question, right? So
yeah, and I have to say, I'm me, I'm always grumpy, I always like to disagree. If you read all the literature about valve durability, they talk about biologic valve destruction, EVD. I think that's nonsense. Because if you look at what makes up EVD, most of it is a prosthesis patient mismatch and aortic regurgitation. So they always say, well, surgical and TAVR valves are equivalent because the BVD is identical. And I think that's really misleading because you know about prosthesis patient mismatch when you put the valve in, you know about it even before you implant it. You can predict it. So it's not a meaningful number in that regard. It's not something that you have to watch and make sure it's developed. It's either got to be there or it's not. What we're really concerned about is structural valve deterioration. And so far, the numbers are low for severe structural valve deterioration. Although there will be some data coming out at TCT that is sick. I'm privy to it and I'm not supposed to reveal it. But in the low-risk population, it's considerably higher at 5 years than it is in the high-risk and intermediate groups.
that's yes. Okay, well, thank you very much for the
This my pleasure.
If you don't have any other question, maybe we will finish here. And thank you very much for staying here with us.
Okay, great.
Thank you, Neal. Thank you. Muy bien. Perfecto, muchas gracias.